Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Hello, and welcome to today's discussion on chronic lymphocytic leukemia, specifically with a focus on combination approaches in the recent ASH 2025 annual meeting. I'm Dr. Jonathan Cohen from the Department of Hematology and Medical Oncology at Winship Cancer Institute of Emory University in Atlanta, Georgia, and I'm pleased today to be joined by my colleague, Dr. Matt Davids from the Harvard Medical School, where he directs clinical research in the Division of Lymphoma at Dana-Farber Cancer Institute. Today, we are going to briefly review some of the most recent updates and results in CLL treatment, specifically focusing on those studies evaluating combination approaches in CLL. So we'll first start by taking a look at the important role of long-term BTK inhibitor treatment with either continuous or fixed dosing as either part of doublet or triplet therapy, and also looking at some non-BTK inhibitor containing induction regimens. So at this year's ASH meeting, the CLL-17 study was presented in the plenary session. And this was an exciting study in that it was one of the first to directly compare two of our standard approaches to untreated patients with CLL. The first being long-term single-agent BTK inhibitor versus time-limited therapy with obinutuzumab and venetoclax. And then the study had a third arm, combining ibrutinib with venetoclax, also in a time-limited fashion. The goal of this study was to evaluate for non-inferiority and progression-free survival. And what the investigators found in the study is that at least at the 3-year mark, there does not appear to be any impact on progression-free survival, regardless of the approach that you take. So patients who received ibrutinib single agent indefinitely had a very similar progression-free survival to those who received obinutuzumab venetoclax, as well as to those who received ibrutinib and venetoclax. And so this, again, was one of the first studies to compare these approaches head-to-head, and it certainly speaks to the potential use of combination therapy in a time-limited manner, as opposed to requiring indefinite treatment, which had been previously one of our standards. And so ultimately, this would suggest that fixed duration therapy is an effective option. I would caution, however, that at 3 years, it's probably too early to definitively know whether there will be an impact on progression-free survival. And so with additional follow-up, it will be very interesting to see whether there's any new trends that emerge. We recently also had the results of the Amplify study, which evaluated fixed duration dosing with acalabrutinib-containing regimens. This study, which again was for patients with treatment-naive CLL, randomized patients to receive acalabrutinib plus venetoclax for 14 cycles, the triplet of acalabrutinib plus venetoclax plus obinutuzumab, or a third arm, which was an investigator's choice of chemoimmunotherapy. In the Amplify study, similar to what we've seen with other studies comparing novel therapies versus chemoimmunotherapy, we saw an improvement in progression-free survival for patients who received acalabrutinib venetoclax, as well as for those who received acalabrutinib venetoclax plus obinutuzumab. In this case, the 3-year progression-free survival seemed to be the best for those patients who received a triplet, although this does come with excess or increased toxicity compared to the all-oral doublet. These results, however, lend further support to the use of combination therapies administered in a fixed duration fashion as a potential approach for patients with untreated CLL who are receiving their initial therapy. One thing that I think still needs to be determined are who, if anybody, requires triplet therapy. Commonly, we think about that for patients that have high-risk disease, perhaps with deletion 17p or mutated TP53. But for most patients with CLL, it may not be necessary to do the triplet. I think also it's very important to recognize the importance of continued follow-up, especially for patients who are receiving fixed duration therapy, as we may start to see some different trends in relapse or remission duration and behavior at relapse develop in those patients. Matt, do you have any other points to add to these two key studies?
Yeah, thanks for those great summaries, Jonathan. I agree with everything you said, and really emphasizing the point around longer follow-up being needed for both of these studies. 3 years is a very early look, I would say, in the frontline setting for CLL, and we need longer follow-up to understand if there are even differences in progression-free survival with these regimens. And as you alluded to, the toxicity considerations are real here, particularly when you add obinutuzumab. In the Amplify study, they did see significantly higher rates of COVID-related infections and deaths in the obinutuzumab containing arm. And so we do need to be careful with patient selection as we think about triplets. But as you alluded to, there are data that we generated from a phase 2 study, specifically in high-risk patients with TP53 aberration with the AVO triplet, where the results do look favorable. So it is worth considering that as an option.
So now let's switch gears and focus a bit more on some of the minimal residual disease data that came out of ASH 2025. Matt, do you mind summarizing some of these studies?
Sure, happy to. So I wanted to start with the UK FLAIR trial, which is an MRD-guided therapy trial. The study initially started comparing ibrutinib rituximab to FCR, but the trial evolved over the years and added some additional arms, including ibrutinib monotherapy, and then later also ibrutinib plus venetoclax as a combination. And one of the unique aspects of FLAIR is that ibrutinib plus venetoclax is given in an individualized MRD-guided fashion. So what do I mean by that? Well, basically what they did in FLAIR is they calculated the amount of time it took patients to achieve an undetectable MRD state. And then they doubled that amount of time to determine the length of therapy for that particular patient. So for example, if it took 2 years to get to undetectable MRD, that patient would get 4 years of therapy. But at this year's ASH meeting, they actually went into significant detail around some of the genetic subgroups in the FLAIR trial, which was very helpful to understand sort of which patient populations may benefit most. So they did a very detailed mutational analysis. One thing to mention is that this study did exclude patients with deletion 17p, since it did have a chemoimmunotherapy control arm initially, but it had quite a few patients with unmutated IGHV, which is a more aggressive type of CLL. Many of these patients with unmutated IGHV, about a third, actually had 2 or more additional somatic mutations, which could include high-risk factors like TP53, mutation, as well as other factors like SF3B1, ATM, and Notch1, which all suggest a more aggressive CLL clone. And they provided some very helpful survival curves based on these different subsets, in particular comparing IGHV unmutated and IGHV mutated patients. As we might expect with the IGHV mutated patients, they pretty much did well with all 3 regimens, although there was a slight advantage for the targeted therapies. Really, where the greatest benefit was seen in the IGHV unmutated patients, and certainly we expected a benefit for targeted therapy over FCR there. But what was also pretty striking to me was the benefit for I plus V specifically, which had a 5-year PFS of 95%. And that was even favorable compared to ibrutinib with or without rituximab given continuously, which was a 79% PFS rate. And this actually even looks favorable with regard to overall survival. So at 5 years, 97% with I plus V versus 90% with ibrutinib-based therapy. So really, it's this group of patients with TP53 aberration, which I think is most interesting. They showed that the PFS at 5 years in that group was 100% when they were treated with this MRD-guided I plus V. Now, granted, it was a very small number of patients, only 11 patients in that group, but the group of patients treated with ibrutinib continuous therapy was a PFS of 70% at 5 years. So certainly it's not inferior to use I plus V, and this is really one of the most promising regimens we've seen for this high-risk subgroup. I think this study is also a nice proof of principle that if we use MRD-guided therapy, that this can potentially improve PFS and OS, particularly in these poor-risk groups, especially those with TP53 aberration. But I think the FLAIR study also raises some questions sort of around the practicality of incorporating MRD-based therapy into clinical practice. All right, so let's transition now. We've been talking mostly sort of frontline combinations, but we have a very active non-covalent BTK inhibitor, pirtobrutinib in CLL, that was initially developed in a very refractory population, multiple prior lines of therapy. And for years, we were seeing early phase data, phase 1-2 Bruton data. But at this year's ASH, we started to see some big phase 3 data sets with pirtobrutinib in CLL. And so, Jonathan, maybe you can take us through those data sets.
Sure. So I think it is, first, it's impossible to overstate the impact that the covalent BTK inhibitors have had on the management of CLL as well as other B-cell malignancies. And so at this year's ASH, we had a couple of trials that were comparing pirtobrutinib with standard approaches. The CLL 314 study compared pirtobrutinib with ibrutinib in a randomized fashion, with the primary objective looking initially at non-inferiority of the overall response rate, but there were some key secondary objectives which included progression-free survival. And so what we see with the initial data that were presented is at least some evidence that there may be some improvement in progression-free survival for patients who receive pirtobrutinib as opposed to brutinib. This was seen most strikingly in the treatment-naive population, where the 18-month progression-free survival was 95% compared to 88% for patients who received single-agent ibrutinib. One of the potential benefits, however, of pirtobrutinib, in addition to any improvement in efficacy, is that there does appear to be an improvement in tolerability. There's a lower rate of arrhythmias with pirtobrutinib compared to ibrutinib, and some of the other toxicities that we see, including hypertension, may be a little bit less prominent in patients with pirtobrutinib. We do, on the other hand, see an increase in neutropenia with pirtobrutinib, which can sometimes create challenges, especially for patients with CLL. The other study that was presented during the late breaking session was the CLL 313 study, which compared pirtobrutinib with bendamustine rituximab in patients with untreated CLL. This was a study that used a design that was similar to what was used with covalent BTK inhibitors over recent years, to compare one of the prior standard approaches. And not surprisingly, we saw an improvement in progression-free survival with pirtobrutinib in patients with untreated CLL compared to BR, with a 24-month progression-free survival of 94%, and signaled that there may be an improvement in overall survival compared to BR. In addition, we did have a pooled analysis of two studies which looked at the role of pirtobrutinib as a second-line approach for patients who had received covalent BTK inhibitor in the front line. And this is pertinent, as Matt mentioned earlier. There's some concern about the use of covalent BTK inhibitors, especially in an indefinite way, as a frontline, and what impact that may or may not have on response to BTK-targeted therapy in the second line. And so this was a pooled analysis that included a total of 37 patients who were BCL2 naive, had previously received a covalent BTK inhibitor in the front line. And again, they looked at overall response rate as well as progression-free survival. And I would point out that in this particular cohort, 57% of patients came off their covalent BTK inhibitor due to disease progression. And so these were patients that at least had proven or at least demonstrated some evidence of being resistant or potentially refractory to a covalent BTK inhibitor. And the investigators found an overall response rate of 67 to 70%, depending on the response method that you used, with a CR rate of 13%. But what we do see when we look at the waterfall plot is that there is a significant decrease in overall amount of disease from baseline. Now, the investigator assessed progression-free survival was 19 and a half months. So this is certainly a shorter response duration than what we might see in patients who are otherwise BTK naive, who are receiving a BTK inhibitor for the first time, but certainly highlights the fact that this can be a very active therapy when given as a monotherapy in patients with recurrent disease as part of their second-line approach. And so what we see is that there is benefit and tolerability for patients. I think this is potentially appealing for those folks for whom venetoclax may or may not be an option, that have already received a covalent BTK inhibitor and now need a second-line therapy. I do think, however, it doesn't necessarily answer the question of where venetoclax may fit here. I could certainly see this being a potential option in patients who had a covalent BTK inhibitor plus venetoclax as frontline, who now need a second-line treatment strategy as well. And so I think with ongoing follow-up, we'll have a better sense of how to sequence these therapies. Matt, did you have any other comments on the non-covalent BTK inhibitors data presented at ASH?
Yeah, I mean, just to echo what you were saying in the relapse setting, I think the second line pooled analysis is interesting. We tend to see these patients more and more now who are coming off frontline BTKI. My default has historically been to switch them to venetoclax generally, although there are quite a few patients out there who are not great venetoclax candidates for whatever reason. Maybe that's why they went on a continuous BTK inhibitor to begin with. And so this study analysis does give us confidence that we can use pirtobrutinib in that second line setting specifically, which is now on label based on the full approval. Although the median PFS of just over a year and a half does suggest that these patients are going to need additional treatment options beyond this as well. So we need to keep that in mind. I thought from the ASH meeting, really the most exciting data with pirtobrutinib were the frontline data, since we really had not seen frontline pirtobrutinib data in CLL in a phase 3 setting before. And both of these are very strong data sets. And then I think, the questions are going to be, what are the right patients to think about for frontline pirtobrutinib? What kind of follow-up and additional sequencing data do we need to feel comfortable using that? One of my concerns is that we do know that we can use the covalent inhibitors first, and then pirtobrutinib will be active in the relapse setting. We don't have data the other way around yet, where if we start with pirtobrutinib, how well do patients respond to covalent BTK inhibitors post pirtobrutinib? Hard to know until we have data. So that's a little bit something that causes a bit of hesitation for using frontline pirtobrutinib widely. That being said, given the very favorable safety profile of the drug, I think especially if you think about older patients where maybe they only need 1 or 2 lines of therapy of CLL, their pirtobrutinib is particularly appealing, especially in patients who have cardiovascular comorbidities where you're really trying to minimize those risks.
Sure, absolutely. And actually, that's a really nice setup for our last portion of today's discussion, which is looking at some of the studies that are evaluating retreatment strategies in CLL. We know that in general, for patients with untreated disease, we can obtain a remission and typically obtain a durable remission. But most patients over the course of their life will require at least consideration of additional therapy. And so it'd be great to have you summarize some of the data looking at retreatment approaches in patients with CLL.
Sure, happy to do that. So really the only prospective data that we have in this setting so far comes from a trial called REVEN-G, which is retreatment with venetoclax and GA101 or obinutuzumab. This was data that I presented at the spring meetings in 2025. This trial takes patients who previously had frontline time-limited venetoclax-based therapy and treats them with venetoclax plus obinutuzumab now as a second-line therapy. The majority of the patients in this study had at least 2 years of initial remission to their frontline ven-based therapy, although we have a smaller exploratory cohort that had only 1 to 2 years of initial benefit. And the primary endpoint of the study is the overall response rate after the combination portion plus 3 months. And so it's early days still with REVEN-G. This is an ongoing study. So at my presentation, we only had data so far for the first 25 patients with respect to safety. But reassuringly, the safety profile of ven-obin in this relapse setting looks very similar to what we are accustomed to in the frontline setting. We do see grade 3-4 neutropenia in about 30% of patients, as well as infections in that same range. But otherwise, this is a well-tolerated regimen. And so far in the 15 patients who have received that full sort of combination therapy plus the 3-month evaluation, all 15 patients have responded to treatment, including several patients already with complete remission and even patients with undetectable MRD. And we actually looked in this study through next generation sequencing techniques as low as a threshold of 10 to the minus 6th. And even in that setting, 6 of these patients had already reached the deepest level of undetectable MRD. And these are patients still on treatment who need 3 more cycles of treatment. So I think so far, very encouraging results from REVEN-G. As I said, it's an ongoing study, so we'll need more patients and longer follow-up to really better understand the efficacy of ven-obin in this population. At the ASH meeting, we also saw some data for the first time from sort of this observational cohort of patients who had previously been treated on the Gaia or CLL13 trial in the frontline setting. As a reminder, this is a trial that was for all comers except for those with deletion 17p who were previously untreated with CLL, and they received one of 3 different venetoclax-based combination arms, ven with obin, ven with rituximab, or a triplet of ibrutinib, ven, and obinutuzumab. And then there was a control arm of chemoimmunotherapy. And in this analysis, we saw for the first time some of the results for second-line treatment in the patients who had progressed after their initial therapy. And really the theme so far, I would say, is that regardless of what targeted therapy regimen these patients received in the second-line setting, they tended to do well with respect to treatment-free survival. And all these patients had sort of 1-year TFS rates in the range of 80 to 100%, which looked similar in the 2-year setting. So all of these regimens were active post-frontline venetoclax. The one exception really was the small number of patients who received chemoimmunotherapy as a second-line therapy. Those patients had a TFS only in the range of about 28% at 1 year. So again, further evidence that we should not be using chemoimmunotherapy in CLL. And this was true also with respect to overall survival, which looked also very good for the targeted therapy treated patients, but shorter for patients treated with chemoimmunotherapy. So one other, I think, important abstract that we presented at ASH is a trials in progress poster to highlight a new study that's opening right now called Maverick, which is mutation-guided AV, acalabrutinib, for patients who have previously received BTK plus BCL2 frontline therapy. One of the unique aspects of Maverick is that it is mutation guided by IGHV status, because generally we know that patients with mutated IGHV have a more indolent form of CLL. And we've found with numerous studies now with BTK BCL2 inhibitor doublets that these patients can do quite well with 1 year of fixed duration combination. But patients with unmutated IGHV tend to have sooner relapses. And so in this study, if patients have unmutated IGHV, they receive a second year of AV-based doublet therapy, so 2 years total of treatment, versus the 1 year in patients who have mutated IGHV. So it's a bit of a variation on what we've seen before with MRD-guided therapy. So this study will recruit hopefully about 80 patients internationally with a primary endpoint of overall response rate. And as we start to see more AV and even AVO use in the real-world setting, we're hoping that this will be informative data to understand outcomes for retreatment with AV-based therapy for those patients. So maybe just to wrap up, Jonathan, any further thoughts on these retreatment data that I just discussed?
No, I think it's a fantastic summary. I think, to be honest, this is an area of critical importance. Many patients that we see, especially as we're starting to move towards combination targeted therapy of fixed duration, many patients are concerned about what's going to happen when the disease comes back. And so I think as these trials continue to mature, and I think your Maverick trial is going to be similarly very important, I think that will provide additional confidence for us as we are thinking about fixed duration therapy in the front line, and also when we are looking at options in the second line and beyond.
Great. Thanks, Jonathan. Well, always fun to talk CLL with you. Really exciting data. And we thank you as the audience for joining. And we hope that you'll join for future Medscape oncology programs.
Great. Thank you.